So I'm going to talk about updates on transplant, both or therapies, including transplant. I'm going to show you a little data we have for cord blood infusions for CP because it relates to brain repair. A little update on our duoc cells, and then an update on gene therapy. This is more clinically oriented than Allison's talk. We all know transplant has benefit in Krabbe disease if it's performed by 30 days of age, but it's not the solution. There's still peripheral nerve disease that in most children progresses, and so we still need more or better solutions. I think it's fair to say that in transplant, about 10% of kids have really excellent outcomes. About 80% of kids have intermediate outcomes where they have peripheral neuropathy. And I would say generally by the time they're teenagers, they're not walking independently. And then about 10% of kids have very severe outcomes, better than they would be without transplant, but surviving with very severe impairment. And you've heard today, and I'm not going to talk about it, but for late infantile Krabbe disease, the results are much better. The kids are much more functional. Peripheral neuropathy doesn't seem to be as big a problem. I have patients in their 20s who were transplanted in the first year of life or so, who are doing very well. I think we all need to recognize that and rely on newborn screening to find those kids as well. And then for juvenile disease, as you saw this morning, it's a slower progressing disease. It presents with different symptoms, so it's often missed because it doesn't look like quote unquote typical infantile Krabbe. But outcomes also can be better. So, just because pictures tell a story, Dieter showed the kids on the left diagnosed by Dr. Krabbe. When he described the disease, that's an untreated child or baby. But the two kids in my slide, the middle one was diagnosed essentially at birth because of a sibling who died when she was 3, was a homozygous 30 kb deletion. She got a cord blood transplant when she was 19 days old. She's 21, she's in college, she drives, she's cognitively normal. She has a little bit of spasticity in an ankle and had a tendon release operation, but I mean, she's independent and fully functional. So she's in that 10% who really do very, very well. And I do not know why. I cannot tell you from day one who's going to be like this versus who's going to be like the little boy in the next picture who was diagnosed in utero because of a sibling who died when she was 10 months old, but has the more typical course where he's cognitively normal. He uses his upper body pretty well. He's already he's 9 in this picture. This was at the advisory committee meeting, but he can't walk independently anymore and really is wheelchair bound. And, he is adjusted, fits well into his family, goes to school, is in a partial, typically developing class, but, he's got impairment. And that's not going to get better. I would love to take a kid like this and treat a kid like this with gene therapy and see what happened, because he still has nerve conduction. He's not lost at all. But that's another story. Now, the girl in the middle has psychosine in Dieter's lab, but that is quote unquote normal. And I've been starting to look at psychosines in these later surviving patients that I have. And it's been normal for 3 or 4 years that we've tested it, meaning I send samples to Dieter. The little boy has had psychosines for the last 3 years, which were 63, then 81, then 38. These are red cell psychosines. So, to the question of does psychosine predict disease activity and deterioration or not, I'm really not sure. And one patient isn't a whole story, but I think we need more data around that. So I'm going to switch gears for a minute, talk to you about work we're doing using cord blood as an infusion therapy for cerebral palsy. So this is not a transplant. There's no chemo. There's no intent for cells to engraft. We're using the cord blood monocytes as a therapeutic cell. They get engulfed by lung macrophages who then ingest some of their RNA and are reprogrammed to make some of the cytokines they make, which stimulate oligodendrocytes to proliferate. And then that results in remyelination to damaged areas of the brain. And I don't have time to show you all the data, but I put too much data on this one slide just to illustrate that we've done multiple studies. We've used a validated motor scoring method in children with cerebral palsy. I think Laura Case is listening online, but she's the physical therapist at Duke that did most of these studies on our kids. And what we were able to show that was that appropriately dosed cord blood did result in improvement in motor function that was beyond what would be predicted by the GMFCS scale. And that was associated with remyelination of damaged motor tracts in the brain as studied on whole brain connectivity. And I don't think this pointer actually, oh, there it is. So down below on the right are the remyelination studies. And we were able to show they correlated with children who got an appropriate dose of cord blood cells. We did a meta-analysis of our own data, which identified that kids with a GMFCS level of 1 to 3, which is mild to moderate, were the ones likely to respond to this therapy. But the fact that monocytes from cord blood can induce remyelination of damaged neurons is of interest to us. We have a phase 3 trial planned. It was approved by the FDA under RMAT. It was funded by a company, and then the company pulled out. Sounds like a broken record. So we're waiting to fund this trial, but FDA has said that if the trial's positive, they would extend the clinical indication under the BLAs that publicly banked cord blood banks already have to include cerebral palsy. So just because I think a picture's worth 1,000 words, here's a kid at baseline coming onto the study, and you can see he has spasticity and he's scissoring and he walks with a walker and wears AFOs. And then here's like Laura's voice.
Have a nice job. Did you consider it first?
Oops, sorry. So we scored that, sorry, but we scored that as more improvement than would have been expected for a kid with that level of disability a year later. And that's the kind of results we saw in our trial. And I didn't say this, but kids eligible for the trial were, in this case, 1 to 5, had to have CP due to prematurity, HIE, or an in utero stroke. So it was a restricted population of children. That led us, though, to look at engraftment of cord blood cells in the brain. I've showed some of these pictures a lot, but in the upper left, you can see the brain of a child with Krabbe who was transplanted at 10 months of age with symptoms and who died of aspiration pneumonia at 20 months of age, and whose parents let us study her brain. And this is now 20 plus years ago, but it was the first evidence that we could show that donor cells actually engraft in brain. So the green dots are Y chromosomes in this female child who had Krabbe disease who was transplanted with a male donor. The cells that engrafted in the brain were microglial cells from the donor, and that allowed us to go back and develop a cell therapy product. Swimming around in the lower left, we call DUOC, which stands for Duke-O-cell, and which in various experimental systems, including the middle boxes, which is the Cuprazone assay, can remyelinate brain that is demyelinated experimentally. And on the right, in the experimental autoimmune encephalitis model, can rescue the mice from ascending paralysis if injected intrathecally on the day the first symptoms of ascending paralysis develop. This is just a little bit of the landscape we've looked at. So DUOC, which we give as an intrathecal cell, has been given to 35 kids in a phase 1 study of leukodystrophies who were transplanted and then given a single dose of DUOC intrathecally, with the top dose given 10 million as an absolute number of cells. And we established safety and formulation, which is Ringer's lactate with 3 milligrams per mil of hydrocortisone. And then because we really could not assess efficacy in kids getting a transplant and an intrathecal therapy, we've just finished enrolling a study in 19 adults with primary progressive MS, getting exclusively DUOC as a single intrathecal dose up to 50 million cells. And we're just at the point where we finished enrollment. We have 3-month and 12-month efficacy endpoints. So I will have the 3-month by the fall and the 12 months by next summer, but we're hoping to see some in vivo sign of remyelination in those patients. And there are multiple scores and MRI scoring techniques that allow us to look at that in a patient with multiple sclerosis. And the reason I'm presenting this is just to say maybe someday, like Allison and your dogs, we do the gene therapy and then we come back later and repair a lesion that's, deteriorating, if it's clinically significant, not just to do it. But there may be combination therapy that ends up really saving the day. Allison alluded to this, but gene therapy in Krabbe has a very similar story to gene therapy in a lot of other rare or ultra rare diseases. And mostly it's that it's very unattractive for commercialization. It's too small a market, it's complicated, and companies just don't want to do it. But Passage Bio was the first in the field. They had an intraforamen magnum, believe it was an AV9 therapy. They treated one patient. They had a protocol where they were going from symptomatic to pre-symptomatic babies. They treated one 9-month-old symptomatic baby who tolerated the therapy well, developed hydrocephalus, which can happen in Krabbe disease and may or may not have had anything to do with the gene therapy. But then they dropped the program for financial reasons. The Neurogene, Allison told the story, but they were in preclinical development. They never submitted their IND and dropped the program, again, for financial reasons. And then Forge, which got the farthest along, has an AAV10 IV therapy after cord blood transplant, so similar to the dogs that Allison showed. And the plan was to explore 2 dose levels, a low and a high. To date, 6 kids have been treated, 5 on the low dose, 1 on the high dose. And they decided to drop the program last December. The company was also sold to another company in the months that preceded that. And I don't know what really prompted what, but I do know that they felt it wasn't worth their investment any longer, I would say. Now, the current trial, though, is open because there's a high-dose patient, the only high-dose patient who happened to be treated at Duke, and I'll talk about him in a minute, who is still being followed. And I will say our hope is somehow to figure out a way to at least finish that high-dose cohort under some kind of EAP. Forge originally had 2 trials, Rescue and Reclaim. Rescue was for newly diagnosed infantile Krabbe disease babies who got a transplant and went right to gene therapy sometime 21 days after engraftment. I think there was one case on the low-dose regimen that was treated that way. I don't have the data. And then they switched to a study they call Reclaim, which is the current trial, which finished the low dose and also was intended to treat 4 kids on a high dose cohort. And the treatment was allowed at any time post-transplant, and there were certain eligibility requirements. The most important ones were that the kids had to have negative anti-AAV antibodies, couldn't have an active infection, couldn't have grade 2 to 4 GVHD or severe organ dysfunction. And I'm just going to show you you learn, or hindsight's 2020, I guess is the saying, but any form of Krabbe disease, as babies or toddlers who were treated when investigational product was available and when they were available, and that often involved a referral to one of the 3 centers that did participate in this trial over time. One was at started at University of Pittsburgh, then it went to University of Michigan, then it went to Children's Hospital of Orange County, and then it came to Duke. So there are a few kids treated at each of those locations. The fact that they had to have negative anti-AAV antibodies caused trouble because during transplant, most kids are supported with IVIG, and there are anti-AAV antibodies in IVIG, which is made from generally 3,000 people who donate their blood. And you can't tell at any given time, is the antibody really from the baby or is the antibody from the IVIG? And in order to figure that out, you have to stop giving IVIG. And sometimes that's possible, sometimes it's not. And the time to wait is usually 8 to 12 weeks. So that delays a patient getting to gene therapy. The protocol has since been amended. So for kids under 6 months, you don't have to measure anti-AAV antibody. They can't have active infection, but, and I'm going to talk about this kid who's Paul's kid from Minnesota, but he had reactivation of CMV during transplant, which is very common, which is asymptomatic generally and is treated with an antiviral and goes away. But is that an infection or isn't it? And do you wait till that clears or not? I say no, but there's problems like that. And then GVHD, depending on timing, could occur after you give the gene therapy, and how are you going to interpret that? And then there are common just transient post-transplant complications like pericardial effusion or cholestasis, or mild laboratory abnormalities that if you're a transplanter, you kind of say, yeah, fine. You know it comes and you know it goes. But if you're doing a gene therapy study, it gets to be more complicated about what's relevant or not. And if you delay too long, I don't think the benefit of the gene therapy would be realized. Also in the Ford study, there were multiple decision points for immunosuppression or not before and after the gene therapy, dependent on time from transplant. It was tailored to the immune function of the patient at the time of gene therapy. If Rituxan was given, then the patient won't have B cells for months. But if there was T cell or B cell function, then there were preps with ATG or steroids, and then post gene therapy treatment with either steroids or Tacro or MMF or all three. So it was, I think, appropriately tailor-made to the patient, but it wasn't one single regimen that was followed by all patients. This is Paul's patient who was their first positive newborn screening patient, and they did a really great job with this patient. He was 5 days of old age of when he was referred. Paul's laughing, but it's true, right? And cytosine was 31 in Dieter's lab. Gal-C was 0.01 in Dieter's lab, with normal being greater than 0.3. I'm sorry, the mutations are listed in such small type, but they were pathogenic. CSF protein was high, MRI was normal, EMG was abnormal. Baby was prepped with Rituxan for 3 doses, 2 before and 1 after transplant, HG, Cytoxan, fludarabine, busulfan, and got IVIG for supportive care, which is appropriate after Rituxan. He was transplanted, I think, on day 25 of life, which is great. He grafted on day 15. Because of this regimen, and I'm not going to go into the nuances, his chimerism was full donor in his myeloid fraction, but mixed in his lymphoid fraction, which was really minimal because he was still recovering from the Rituxan. So that takes more time. And he got another dose of Rituxan on day 28, which is part of the Minnesota protocol. He had complications that are pretty routine for transplanters, but he reactivated CMV. He also had a central line infection and had a few thromboembolic lesions in the brain, which complicated the interpretation of his post-transplant MRIs, but ultimately resolved, and a pericardial effusion, which ultimately resolved. He was enrolled on Reclaim. And he was treated at roughly 6 months of age with 1 high dose of the vector. And from a clinical perspective, he had laboratory evidence of TMA about 5 days out with a drop in his platelet count, which resolved spontaneously without treatment over the next 3 days. but he never had any clinical reactions to the gene therapy. Since he's been developing many normal developmental milestones, he's 15 months of age. I'll show you some pictures, but he sits, he says words, he crawls, pulls to stand and cruises, but he's not walking independently yet. His MRIs have been stable and his nerve conduction, which is mildly abnormal, has been stable. So, I mean, here he is, just some still pictures from a year to 15 months of age. And here he is. I think you can see when he walks that he's got some truncal weakness and doesn't completely pick his feet up. Here he is walking with a different walker where he's got AFOs on. This is when he was about a year of age. And here he is. There he is. We're recently in a swimming pool crawling. You can see when he sits, his trunk is kind of weak, but still he's sitting. And then here are just a few more pictures of him standing. He'll pull to stand on the piano, but he won't walk. So I'm going to stop. But I want to just summarize some challenges. The development and commercialization of these novel therapies, including gene therapy for ultra-rare diseases, is challenging. There's no market for big pharma and its complex manufacturing. I think we ought to do it in academia and figure out some way to get the federal government to fund it. I know that's a pipe dream right now, but I still think we ought to try. We need a registry. I can't keep all these patients in my head anymore. And David Wenger's got, I don't know how many in his head. And Dieter's got a whole bunch, probably more than in his head. He's got a database, and Amy's got a bunch. I mean, we need a database so we collect all this information and know what we know and what we don't know. How do we fund the clinical trials? How do we fund development of gene therapy and other cell therapies? How do we commercialize gene therapy for ultra-rare diseases? When Peter Marks, before he left the FDA, he was talking about commercialization without a BLA for academic centers for therapies for ultra-rare diseases, where you would have minimal data, you'd have safety, you could charge for cost for manufacturing of the product and do post-marketing studies. I think that's a good model. And then we also have to contain cost so patients have access. And I think that would contain cost. So I'll stop there and say thank you.